We're moving along to presentation by Madeline DeAngelo and colleagues from the University of Utah. This is entitled Long-Term Functional Decline Following Vascular Surgery Among Vulnerable Adults.
Good morning. My name is Madeline DeAngelo, and I'm a second-year medical student at the University of Utah. Thank you for the opportunity to present our data. I have no disclosures to report. Vascular surgery is known to be a major physiological stressor that commonly leads to decline in the functional status and independence among patients during the immediate postoperative period. After a period of recovery, some patients return back to their baseline level of functional independence. However, functional deficits may also persist over time in some vulnerable patients that lose independence. The question is, how do you identify vulnerable patients at risk of losing functional independence following vascular surgery? The Vulnerable Elders Survey, also known as the VESS 13, is a patient-reported, function-based screening tool available to the public through RAND, designed to identify older persons at risk for health deterioration. The objective of this study was to evaluate whether the VESS 13 could be used to identify patients at high risk of losing their functional independence after vascular surgery. We prospectively enrolled 126 patients who consented for elective vascular surgery at a single academic medical center between 2018 and 2019. As you can see, the procedures they underwent represented a wide range of minor and major vascular procedures. Patients completed the Vulnerable Elders Survey 13 prior to surgery. This patient-reported survey instrument uses age, self-rated health, physical function, and functional disabilities to risk stratify patients. A score of 3 or greater stratified patients into the vulnerable group, and patients that scored less than 3 were considered non-vulnerable. Based on this scoring algorithm, 55 patients were considered vulnerable and 71 patients were categorized as non-vulnerable. At the time of enrollment, we established baseline levels of functional status for all patients using the KATZ Activities of Daily Living Survey and the Lawton-Brody Instrumental Activities of Daily Living Survey. The KATZ ADLS assesses independence for bathing, dressing, toileting, transferring, continence, and feeding, while the Lawton-Brody IADLs assesses independence on more detailed tasks, including using the telephone, shopping, laundry, mode of transportation, preparing food, housekeeping, taking medications, and handling finances. Patients completed these surveys preoperatively as well as at the 2-week, 1-month, and 1-year postoperative time points to determine whether any functional decline had occurred. Logistic regression models were used to estimate the association between vulnerability status and risk of decline after surgery based on KATZ and Lawton-Brody surveys after controlling for confounders. The characteristics of patients included in the study are shown here. As you can see, vulnerable patients were more likely to be female, older, and have chronic kidney disease. There was no difference in the type of procedures across groups, with the exception of vulnerable patients undergoing a major amputation. Vulnerable patients are shown in blue and were significantly more likely to experience a decline in functional status defined using the KATZ ADL survey when compared to non-vulnerable patients. This was seen at all time points, including at 2 weeks, where 25% of vulnerable patients had a decline in ADLs when compared to baseline status. But it's also important to point out that 18% of vulnerable patients continue to have an overall decline in their functional status at 1 year, compared to only 7% of non-vulnerable patients. A similar trend among vulnerable patients was also observed when functional decline was assessed by changes in the instrumental ADLs using the Lawton-Brody survey. As you can see, a significantly higher percentage of vulnerable patients experienced functional decline at all time points when compared to non-vulnerable patients. This was most pronounced at 1 month following surgery, but still persisted at 1 year, where 29% of vulnerable patients still exhibited functional decline in instrumental ADLs. The specific ADLs where vulnerable patients were found to have the greatest decline at 1 year involved bathing, dressing, toileting, and transferring. Whereas in terms of the instrumental ADLs, vulnerable patients were more apt to experience functional decline in the ability to prepare food, manage medications, and do their finances. Finally, these findings were confirmed when we used logistic regression models to estimate the association between vulnerability and functional decline in ADL and instrumental ADLs at 1 year while adjusting for age and procedure type. As you can see, vulnerability was associated with a 3.3 increased odds of decline in ADLs and a 2.6 increased odds of decline in instrumental ADLs when compared to non-vulnerable patients. In summary, our study highlights the ability of the VESS 13 to identify vulnerable patients before surgery who are at risk for significant decline in functional status up to 1 year following elective procedures. These data suggest that the VESS 13 should be used as a routine screening tool, allowing surgeons to prepare vulnerable patients and their caretakers for specific functional limitations that are likely to occur in the post-operative period. Thank you again for the opportunity to present, and I'm happy to take any questions.
Thank you very much. That was an excellent talk. We have some questions coming in from the floor. Very nice job presenting this important addition to the literature. Is your VESS 13 incorporated into your EMR? And at what time point in the patient's care is the survey administered, in the clinic, in the hospital, etc.?
Hi, thank you. Just want to make a quick correction really fast. On the presentation, it had MD after my name. I'm still a medical student, and I'm not a full-fledged physician yet. So to answer the question, we currently do not have it integrated into our routine workflow or anything like that. And the survey is administered prior to the elective surgery, just in the preoperative period before the patient experiences the operation they are going to have. And then again, like I said in the presentation, at 2 weeks, and then 1 month and 1 year. And there is a little bit of wiggle room for those survey administrations to be collected from the patient.
I see. Question essentially combined from my co-moderator, Dr. Smeds, and from Dr. Brody. Any particular procedures that put patients at more or less of a level of decline? Did you see any difference between, for instance, endovascular or open procedures or anything like that? Because I know that you had a wide range of procedures that you were studying.
Yeah, we did have quite a wide range of procedures that we were studying, and just kind of glancing at the data, there tended to be a little bit more of a dramatic decline after these major surgeries. But something important to point out in our logistic regression, vulnerability was associated with an increased likelihood of decline in ADLs as well as the IADLs, and that was after adjusting for the patient's age as well as the procedure type categorized as a minor versus major procedure, highlighting that vulnerability is really what is impacting this decline and not necessarily the procedure type over the long term.
I see. So you guys did classify procedures into minor and major. Correct. Based on an internal. I see.
Correct.
Another question from Dr. Kavar. Great work on a very important topic. How did you define significant decline on the KATZ and Lawton-Brody scales?
Yeah, great question. So when we were looking at the survey responses, functional decline was classified as kind of a dichotomous variable, comparing their pre-op score to their post-operative score. And so looking at their pre-op and then, for example, their 2 weeks post-op, those numbers were compared. And kind of like I showed on the graph there, we just calculated the percentage of patients with functional decline after vascular surgery for each of those time points, comparing whatever, if it was 2 weeks, 1 month, or 1 year, back to that preoperative value.
I see. Another question from the floor from Dr. Janko. Great presentation. Have you considered administering the survey to the patient and their caregiver? I would be concerned about possible bias if some of my potentially older male patients were asked to acknowledge their limitations.
Yeah, that's an excellent point, and something that we are kind of considering, not totally sure how to take that into account. Something that's important, I think, to highlight that could be a potential limitation of this study, depending on who is in the room or next to the patient while they are while they're answering the survey, that could introduce a little bit of bias into the study. However, this likely would have affected both vulnerable as well as non-vulnerable patients equally. So I guess not a perfect answer to that question, but something we are still trying to figure out how to address properly.
Most definitely. I'm interested to see you guys, if you have any ideas in your group about interventions that you can actually take based on this survey data. I mean, it's very telling that a lot of these people do very poorly in terms of functional status. And we've known that anecdotally for a long time. But have you guys talked about any prehab or counseling or anything specific, even though you haven't integrated it into your workflow?
Yeah, to the best of my knowledge, nothing specific has been integrated at this time. I think this data is really just showing us that it opens up a conversation for some type of intervention to be put into place for each patient that may end up being unique to that patient's needs, depending on how vulnerable they are even before their surgery, as well as what type of care they have access to at home versus with whatever their insurance will allow them to receive. But at this time, we haven't really started any type of program as a generalized way to approach this. It's more of an individualistic thing. It opens up a conversation for the provider to have with the patient about how to preoperatively employ strategies to mitigate that loss of independence that will potentially incur after the surgical event.
Great. I think we have one more question here from Dr. Wolar. He says, the VESS 13 is self-reported. Are there any more objective ways to validate or corroborate your findings? And have you guys thought about that?
Absolutely, yes. So actually right now we are also looking at frailty using the clinical frailty scale. And the clinical frailty scale is not a questionnaire, but more so a way to summarize information from a clinical encounter of a provider with a patient and in this context, it can be used to roughly quantify an individual's overall health status. And since this is done by the provider, it is a little bit more of an objective versus a subjective evaluation. And in our preliminary findings so far using the clinical frailty scale as another way to risk stratify patients, we are actually seeing that this is a more sensitive way to risk stratify patients. However, this can be a little bit more time and more work for the provider because they're the one doing it versus the patient self-evaluating. So kind of both sides of the coin there between how sensitive these patients are being risk stratified and the amount of time that is going into the tools that we're using to do it.
Yeah, I know my institution in particular has already implemented a frailty scale for everybody who comes into my clinic. So everybody who comes in gets an RAI evaluation. And even though it's a pain, it gives you a little bit more information. So it'd be very cool to see in the future if you guys can integrate the two. into something that can really give us a solid idea of this kind of stuff that we all know anecdotally, but put some hard data to. So thank you very much. I think that's the end of the time, and we'll go ahead and move along. Thank you.